Welcome to the GAPP MASLD MASH Community Network. My name is Lindsay Pratt, and I am a PA. I've been practicing for 15 years. I started in private practice gastroenterology for a couple of years, and then the last 13 years I've been with University of Colorado in the Department of Hepatology and liver transplant. So I see patients with a variety of liver diseases all the way up until transplant. So excited to be here with you. Oops, it's not letting me advance. There we go. Okay, so today we're going to be discussing non-invasive testing for fibrosis using a case. And you can use this QR code to record your attendance for this meeting. And I'd also invite you to use this QR code too to visit the GAPP MASLD MASH community network. It's a great website, lots of information and videos on MASH disease state as well as treatment. Okay, so to kind of conceptualize the use of NITs, we're going to begin with a clinical case study. So this is a very typical patient that might present to primary care or to GI or hepatology with concern for MASLD. So this is a 65-year-old Hispanic male with a BMI of 29, so just kind of right on the border of obesity, referred for elevated liver enzymes and an abdominal ultrasound remarkable for increased echogenicity, which is consistent with hepatic steatosis. His past medical history is pertinent for no alcohol since his 20s. He does have multiple cardiometabolic risk factors, including type 2 diabetes, hypertension, and hyperlipidemia. On physical exam, he has abdominal adiposity, but no stigmata of advanced liver disease. So there's no caput, no splenomegaly, no ascites, no spiders, and you do note the elevated BMI. In terms of labs available, as you can see here, triglycerides were 89, HDL 41, the hemoglobin A1C is elevated at 7.2, and he has known elevation of his ALT 1 to 2 times the upper limit of normal for the past 3 years. And there's been a preliminary evaluation to rule out other causes of chronic liver disease, such as viral hepatitis, autoimmune hepatitis. So, this patient, the suspected diagnosis here would be MASLD, the metabolic dysfunction-associated steatotic liver disease. And we know with these patients that fibrosis is really the driver of poor clinical outcomes for these patients. So the next step is really to determine, does this patient have significant fibrosis that would put him at risk? All right, so the landscape for non-invasive assessment of liver disease in 2025 is quite broad. So we have now imaging biomarkers of fat in the liver based on ultrasound, MRI, and then imaging biomarkers of liver stiffness that include shear wave elastography, ARFI, vibration-controlled transient elastography, or FibroScan is an example of that, as well as MRE or MR elastography. We have clinical prediction rules for fibrosis. So lab-based would be your FIB4, the NAFLD fibrosis score, and the APRI. We have proprietary serum markers for fibrosis, which would include the ELF score as well as some others you can see here. And then we have combined rules that combine either FibroScan with AST or MRE with these other lab values to create these prediction rules for advanced fibrosis. And just in the interest of time today, we're just going to focus on the ones that are highlighted here. Okay, so the FIB4 is usually the first NIT or non-invasive test that we recommend using, and we really want to encourage our primary care providers to be using this test as well. The nice thing about it is that all you need is the patient's age, their platelet count, and their ALT and AST. So you really just need a CBC and a CMP. A lot of medical record systems now, for example, if you're on Epic, have a dot phrase. You can just put in dot FIB4 and it will auto calculate the FIB4 for you. So a FIB-4 score of less than 1.3 has a high negative predictive value for excluding advanced fibrosis. Conversely, a FIB-4 score greater than 2.67 indicates an increased likelihood of advanced fibrosis. So and patients that fall either in that indeterminate range between 1.3 and 2.67 or greater than 2.67 do warrant additional testing. There we go. Okay. So the ELF score, the Enhanced Liver Fibrosis score. So this is a proprietary blood test that looks at three markers of cellular matrix turnover, which is a marker for fibrosis development. It is a very good test in terms of sensitivity and specificity. And this graph is just showing that your specificity for advanced fibrosis increases at these higher ELF scores. I'll be honest, we probably underutilize the ELF in our practice. It is a send-out test, so you've got to use LabCorp or Quest, and it's not always covered by insurance, so you just worry about your patient getting a huge bill. But it might be something that if you want to use to have your patient just double check that their insurance is going to cover it, because it's otherwise a very good test. Okay, so moving on to kind of more of the liver stiffness based tests as NITs. So stiffness is the ability of an object to resist deformation in response to an applied force. And we know that shear waves travel faster through a stiffer liver, and that liver stiffness increases with the fibrosis stage. So here we're seeing just kind of the four different types. So transient elastography or FibroScan, the MR elastography, which generates this nice colored elastogram, and then the point shear wave and two-dimensional shear wave elastography. Okay, so vibration-controlled transient elastography, or VCTE, otherwise known as FibroScan. So this is a nice point of care test. We're fortunate in our clinic that we can just kind of walk down the hall and FibroScan a patient. It gives you non-invasive quantification of two biomarkers, both liver stiffness and steatosis, as reflected by the GHAPP score, the controlled attenuation parameter. The test only takes about 10 minutes. Some of that is just getting the patient in the proper position. Once you're actually doing the test, it takes literally about a minute to perform. So again, the liver stiffness correlates to the extent of fibrosis, and then the CAP score correlates to the steatosis, the fatty infiltration in the liver. And both biomarkers can be used to assess disease severity in MASH, as well as different etiologies of liver disease. So some things that I consider when I'm reading a FibroScan, so I'm looking at, are there at least 10 valid measurements? What is the image quality? So here you can see this, in this FibroScan, you have nice parallel margins here with your shear wave, good image quality. I'm looking at what the success rate was to obtain the 10 measurements. I also look at the IQR median should be less than 30% for this to be a valid test. And then is the operator experience. So in our clinic, we have our medical assistants performing the FibroScans, and they go through extensive training to make sure that they're really competent with doing this test. So some potential things to consider with FibroScan. There can be some confounding variables. So in terms of labs, if the patient has a lot of inflammation as evidenced by elevated transaminases, the ALT or AST over 100, that can cause the FibroScan to overstage the fibrosis. So they might have, for example, an elevated AST due to recent alcohol use. Ideally, you don't want your patient drinking alcohol leading up to the FibroScan, or they might have elevated transaminases from a lot of inflammation from MASH. Similarly, with cholestasis, that can cause the FibroScan to overstage fibrosis. We do advise our patients to fast for at least 3 hours before a FibroScan, and there have been some tests done, or some studies rather, that show that if a patient ate before a FibroScan, that could increase the liver stiffness measurement by up to 26%, which is significant. Again, alcohol use prior to the test could skew your results. Morbid obesity, BMI greater than 35, which of course is not uncommon in our MASLD MASH population, as well as ascites, liver masses, can really interfere with image acquisition as well as the diagnostic accuracy of the test. Okay, so moving on to MR elastography. So this is again shear wave technology. It utilizes an acoustic driver on the patient and produces these very nice multicolor elastograms. MRE is a great test, probably the gold standard non-invasive test for fibrosis. And we would love to do more of them. I think some of the limitations that we run into are probably the number one is just insurance coverage for an MRE, although I think that is getting better. You do have to consider BMI. So a patient with a BMI greater than 40 just might not be comfortable, or it might not be feasible for them to have an MRE. Iron overload can interfere with results. Non-MRI compatible implants might make a patient not a candidate for an MRE, or significant claustrophobia as well. And things like hepatic congestion, such as, right heart, liver failure, hepatic venous outflow obstruction, could also make the results inaccurate. Okay, so this is just a really nice reference to have that kind of goes over all of these non-invasive biomarkers of advanced fibrosis that we just talked about, the FIB4, the ELF, VCTE, and MRE. And just one thing that I'll call to your attention to, the cutoff points for FibroScan and MRE, they're not apples to apples. So you can see there's very different cutoff points for ruling in or out advanced fibrosis between your FibroScan and your MRE. But this is a nice reference to kind of just keep handy when you're considering using these tests and how to interpret them. Okay, so let's go back to our case. So we've established that the most likely diagnosis here is MASLD, and the next most important thing for us to do is to risk assess this patient for advanced fibrosis. Okay, so we're going to actually use the AGA Clinical Care Pathway for MASLD, and there's a number of these algorithms out there. I think this one is really straightforward and easy to follow. So here's the patient's labs. So just mildly elevated transaminases, platelet count still in normal range. We calculate a FIB4, which is 2.22. So that puts him in that indeterminate range between 1.3 and 2.67. So he warrants further testing. So if you look at the algorithm here, so first of all, just starting at the top, who should we be screening for MASLD with advanced fibrosis? Patients at risk would be patients with 2 or more cardiometabolic risk factors, which again, the patient in this case certainly has. Type 2 diabetes, very strong risk factor. And then steatosis on imaging or elevated aminotransferases. Again, we did this history and initial blood work. We ruled out excessive alcohol intake, did the initial workup for elevated liver enzymes to exclude other etiologies like viral hepatitis, autoimmune hepatitis. We did our FIB4, which again, he's in the indeterminate range. So we want to do a secondary test. And in this case, we did a FibroScan on this patient, and he actually came out with a KPA of 6.7, which puts him in a low risk category. So this would be a patient that you could refer back to primary care with plan to repeat a non-invasive test again in a couple of years. And in the meantime, just really focus on lifestyle modifications. So I tell these patients to work on weight loss. We know that 7 to 10% total body weight loss can really help reverse that inflammation associated with MASH. I recommend a Mediterranean diet, higher protein if that's safe from a renal perspective, lower carbohydrate, focusing on getting the refined processed carbohydrates and sugars out of the diet, exercise, and then really optimal control of any of their cardiometabolic risk factors. In the case of this patient, especially getting that type 2 diabetes under control, and then you could repeat a non-invasive test in a couple of years. If this patient had come back with a FibroScan between 8 and 12, which would put them at moderate risk for advanced fibrosis, then you could consider another test such as a liver biopsy or MRE. Certainly, if their FibroScan came back with greater than 12 kPa, this patient needs to be referred to hepatology because they're in that high risk category for advanced fibrosis.